we recognize the need to identify those who are most likely to benefit from screening. And some of the big changes in the guidelines at this time is ensuring that we are targeted with our screening approaches. One modification is in the interval of screening, like how often do you have to get a PSA blood test. So if a patient's PSA is normal, there's really no reason to get a PSA, say, every 3 months or every 6 months. In the current guidelines, you can even go for 2 to 4 years without getting a PSA if a patient's risk is really low from the initial testing. And then the other thing we've done is to ensure that to some extent screening is personalized based on a patient's presumed risk for prostate cancer. For example, we know that Black patients or African American patients are more likely to have prostate cancer or aggressive prostate cancer. Patients with a strong family history are also more likely to get prostate cancer. And patients with germline alterations in genes such as BRCA1, BRCA2, or ATM or CHEK2. And so those patients could be targeted for early screening as well as potentially a little bit more frequent screening interval. The key in that expression is shared decision making. It's shared, meaning that the provider, be it a primary care doctor or a urologist, would have a conversation with the patient and really outlining what the benefits of screening are, at the same time outlining what the harms of screening are, and ensure that the patient is well informed of the benefits and what the risks are, and that patient is empowered to make a decision that is best, for them. So it really requires the provider being transparent about what the benefits are and what the risks of screening are, and allowing the patient to make an informed decision. In general, we want to test only if that test is going to change the management of a patient. So for example, with biomarkers, the guideline recommends that these be used selectively. They should not be used routinely or reflexively. So a biomarker should only be ordered if they will provide additional information that may help a patient or a provider make a decision as to whether to proceed with biopsy or not. So for example, if a patient has a low PSA, low PSA density, negative biopsy, there'll be no need to order a biomarker in that kind of patient. However, a patient with a high PSA or high PSA density, say 0.3, with negative MRI and a negative biopsy, but still ongoing suspicion for prostate cancer, a biomarker may help further stratify that particular patient as to whether to proceed with a biopsy or not. In the case of MRI, we recognize that access to MRI may be limited, and so while MRI has been shown to improve aggressive prostate cancer detection, what we recommend is that an MRI may be used in the initial biopsy setting. However, a patient who already has a negative biopsy with no prior MRI, but with ongoing suspicion for prostate cancer, we strongly recommend getting an MRI before proceeding with another biopsy. Great question. We recognize that there is a significant disparity in terms of access depending on where a patient lives or where a provider practices, and that is why in creating the guidelines, we're very mindful of that. For example, with MRI, we do not think that you necessarily need an MRI in the initial biopsy setting, but certainly if you have it available, you can use it. And the other aspect is in the access to biopsy technology with transperineal versus transrectal biopsies, or with fusion biopsies or no fusion biopsies. We recognize that there are limitations in terms of access depending on where a patient or a patient lives or a provider practice. So what we generally recommend is that a provider uses the resources that are available to them with the best evidence available, and certainly if it's necessary, refer the patient to other centers who may be able to provide those services as needed. We recognize that there's significant controversy with respect to screening, using PSA to screen for prostate cancer, and there's quite a bit of myth or misinformation about PSA screening. Some people may feel that PSA screening leads to the spread of cancer, or that prostate cancer is slow growing in all people. That is not necessarily true in all cases. We believe that PSA screening, if done well, actually saves lives. So I think in that situation, it's really dispelling what the myths or misinformation that the patient may have with the best evidence available is, but at the same time highlighting what the benefits as well as the harms of PSA screening, presenting that in a balanced way to help patients decide whether they want to proceed with screening or not. Absolutely. I think there are still a number of exciting things that are happening in this space at this point. For example, with MRI, there are studies now that have looked at biparametric MRI versus multiparametric MRI that may significantly reduce the scan time as well as the comfort for the patient, reduce the cost of the MRI, and potentially increasing access to MRI. And then the other evolving thing is newer biomarkers that are being evaluated, even potentially in the screening space. A good example is STOCKHOLM-3 that is currently being planned for a randomized controlled trial in the screening population. And then another area that I think is really evolving is the application of artificial intelligence in improving our ability to interpret MRI images, in improving our ability to interpret histology images, or taking in an integrative manner all of the different data points, PSA, MRI findings, or clinical parameters, and building an algorithm that can potentially identify patients who are in the best position to benefit from screening. So those are all exciting areas that we look forward to studies demonstrating how to implement them in our practice.